going to go ahead and get started. Just want to welcome everyone to this webinar on instrument confusion, expecting the wrong screen or assessment to achieve the correct objective. This is a common problem that Dr. Hoffman has addressed across many audiences. We're really excited to share more about this important topic today. My name is Valerie Bagley. I'm the Chief Program Officer here at the Change Companies. And I think just a couple of quick housekeeping things. First of all, there are no CEUs offered for this webinar. That is a common question that comes up. Second, there will be a recording sent over to everyone who has registered for this webinar following this event. So you can expect that on Monday next week at the very latest in your inbox. Feel free to share that out with others who you think may benefit from this topic. And as a final note, there is a Q&A panel in your Zoom screen. So do feel free as this webinar progresses to drop in your questions. We'll try to get to as many as we can at the end of this webinar event. But without further ado, it is my pleasure to introduce our guest today, Dr. Norm Hoffman. Dr. Hoffman is a clinical psychologist who is a nationally and internationally recognized expert in the clinical assessment of mental health and substance use disorders and in the evaluation of behavioral health programs. Dr. Hoffman has worked with private organizations and governmental agencies in a variety of states and countries. He's developed assessment instruments used throughout the United States and Canada, as well as in several European countries. Instruments include brief screens, detailed diagnostic interviews, and treatment planning aids. He was the founder and science officer for the largest independent outcome evaluation system in the US and has authored or co-authored more than 220 publications. What a gift for us all today. As you can see, there's no one probably in the country, maybe the world, better equipped to speak on the topic than the wise and experienced guest that we have with us today. So without further ado, Norm, I'm going to hand it over to you.
Okay, if you can advance the slides. Assessment is really a continuum. Screening is used to determine whether or not an individual requires more assessment or requires evaluation for a given condition. It can also be used to make some preliminary decisions as to where to make referrals. A diagnostic assessment, on the other hand, should be more definitive and could be the first part of this treatment consortium. Treatment planning and treatment results monitoring and treatment outcome monitoring will not be covered very much in this session, other than to point out that for outcome evaluation, you do not need a so-called evaluated or validated instrument. You need some basic questions instead. So we go to the next slide. This kind of graphically shows the continuum. Screening is for conditions that are not the presenting complaint. So you would screen for substance use disorders in a mental health clinic, perhaps, and screen for mental health conditions in a substance abuse treatment program. But if you're working in a substance abuse treatment program, a screen would not be an appropriate tool to use there. That would be from the Department of Redundancy Department, because the individual has already been determined that there's a risk for having a substance use disorder. That's why he or she is there presenting for an evaluation. So at that point, you need to go to a full diagnostic assessment, which is necessary but not sufficient for a treatment plan. The treatment plan has to consider all kinds of other factors that might enter into the equation, like readiness to change, the social network the individual lives in. Even logistics can be an issue in designing a treatment plan. The discharge plan then is, okay, what is the individual going to do once formal contacts are discontinued? And outcome monitoring is, how can we determine whether the treatment worked or not? The next slide. This lends itself to continuous clinical improvement. So you have patient assessment, which you see at the top, and that should drive a treatment plan, which in turn should result in some kind of treatment response. If it's not adequate enough, it may require going back to the treatment plan and making some modifications there. In some cases, it may also inform some changes that should be made in the initial assessment. The treatment will result in an outcome, whether good, bad, or indifferent. The major issue for most people of concern is did the individual achieve remission or not? Societal benefits, financial benefits may be of interest, but usually are secondary to the issue of whether the person achieved remission. And I use the term remission rather than recovery because recovery is really a lifelong process, whereas remission is clearly defined in the DSM-5 as not having any of the 11 diagnostic criteria over a defined period of time. Next. So the principles are instruments are tools to be used by human beings. They are tools. They can be used in many cases in a variety of ways or settings. For example, you can use a screwdriver to tighten a screw or pry the lid off a paint can. It's up to the individual as to how the tool is used. Too often people wind up being servants to the tool rather than vice versa. And the final issue is I'll get that right yet. Humans make decisions, instruments don't. And as you'll see in the next slide, it applies to computers as well. A computer program can make a diagnosis when it is licensed for independent practice in your state, not before. Computers are wonderful. I use one almost every day, but computers do not have the integrative capacity, even with artificial intelligence, that humans have, and the judgment that is required by the appropriately trained clinician to make decisions. Next. So, some things to keep in mind. No single tool can do everything. There is no such thing as a universal assessment tool. Screening and diagnostic assessments are essentially mutually exclusive tasks. One is short, fast, and as we'll see, and the other is definitive and comprehensive. Those are two different tasks for two different purposes. Developing an intervention or treatment plan, as I said, requires more than an assessment. It requires consideration of other factors that may impinge upon the treatment process. But individualized treatment does require addressing individual needs and issues, beginning with an assessment of all of the conditions that the individual might be facing. In some cases, assessment can indicate prognosis. That would be a topic for yet another webinar, perhaps, because I don't think we'll have the time for that here. The thing to keep in mind is you don't want to overload a given assessment task. Next. Or you get this, you've got everything included, except you're not going anywhere. You don't want to overload the system. You want to do things in a phasic kind of thing, fashion, as to say. Next, please. Okay. As I mentioned before, screening and diagnostic assessments are often confused. Screening is typically appropriate for determining risk for a given or to make an initial decision, perhaps. Assessment should be comprehensive and definitive. The difference, I think, if you want to think about it, is the difference between a screen and an assessment. A mammogram or a colonoscopy is a screen, but you would not make a life-altering decision based on either a lump or a polyp. You would want the definitive biopsy to determine whether the object you're looking at is malignant or not. So the screen can identify risks. The assessment should be making more official and comprehensive information for decision-making processes. Next. So screening versus diagnostics. Let's start with screening next. Screen can be oral or written. You can embed a screen in a list of other questions that are asked when an individual is checking in. If you've had any physical lately, you probably have encountered a screen for depression, which is mandated with the 9 questions about depressive symptomatology. The screen should be fast, cheap, if not free. And we're going to talk about a totally free instrument for substance use disorders, as well as a couple of short screens for PTSD and depression. They should be administratable by any designated individual. You don't have to be a clinician to do a screen. Just about anybody should be able to do that. There should be some, in ideal cases, flexibility in the use, and we'll cover that in terms of the different kinds of errors that screens are prone to make, and provide some kind of estimate of the odds that the individual has a problem or not. As I mentioned, and we'll repeat, a screen should never be the sole basis for making any life-altering decisions. Now let's see what the screens assessments look like. Assessments ideally should be a structured interview of some sort. They might be administered by a technician or a clinician, but in the end, the professional with the appropriate credentials and expertise in the area under consideration is the individual who will have to make the final call. And that individual may bring in other kinds of information from other sources, like the patient history, prior treatment episodes, and the like. The assessment should be as complete and definitive as possible, preferably orally presented, because that way you can verify that the individual truly understands the question that's being asked. Next. Sensitivity and specificity are the 2 means of documenting whether or not a screen is being accurate. Sensitivity is the proportion of people with the condition that you correctly identify as having the condition. And the error of sensitivity is a false negative. You've missed the individuals that have positive indications for the condition. Specificity is the opposite. It's the proportion of persons without the condition that you have identified as not having that condition. The specificity error is a false positive. So our mistakes, if you will, are either a false negative of missing somebody that has the condition as being screened as not having the condition, or a false positive where the screen indicates the person has the condition, but in fact, the individual does not. Next. Now, as sensitivity increases, specificity will decrease. But put it another way, if you want fewer false positives, you're going to have to tolerate more false negatives. If you want to eliminate all the false negatives and make sure that everybody who's screened positive does in fact have that condition, and to decrease your false negatives, then the converse will be the case. In other words, if you wanted to have nobody falsely indicated as having a condition, you're going to have to tolerate some false negatives that people will slip past you in the screening process. On the other hand, if you want the opposite, then you're going to have to tolerate errors in the other direction. Typically, we want to balance the errors, but you should be able to, for most screens, be able to consider some kind of relative cost for the types of error and adjust the cut score on the screen to accommodate that. Next, please. Okay, screening accuracy is determined by a number of other factors. One is who's asking the questions. We have found that in correctional settings, having a sworn officer in uniform doing the screening does not work. This may come as a startling shock to many of you, but arrestees do lie to cops. The timing is also an issue. Doing it too early, too late, or at the right time. If you are dealing with a mental health clinic, you don't want to necessarily do the screening too early to distract from whatever the presenting complaint is. You also don't want to wait until the person is walking out the door, because at that point you have limited ability to do anything about it. Competing activities, again, in a correctional setting, trying to screen during the booking process is not recommended. You want to wait until after the person settles in. The same thing would be true for conditions, screening for mental health conditions, for example, in a residential treatment setting. You'd probably want to consider that later on if you haven't already done it as part of the assessment. And finally, the setting, does the person feel safe or able to be honest? Is it private? And that sort of thing. So those are issues that will affect the accuracy of the screening process. Next, please. For most conditions, a screen of 2 to 6 questions is about all you really need. The short screens are often more accurate than the long ones, for a reason I'll point out in a minute. Screen should have only 1 item per criteria. If you have multiple items on the same criterion, you're likely to get less accuracy in the screen. The content should be clear, direct, and having only 1 issue per question. You want to avoid double barrel questions of, have you experienced this or that? Next, please. The UNCOPE is a universal screen for substance use disorders. It was meticulously developed for the ATOM system, which is the drug abuse monitoring system. And we were charged with trying to come up with a diagnostic indication for individuals that would supplement the information they were getting from urine analyses that were being collected from people recently booked into various local jails around the country. We started out with over 15 items, looking at various screens and assessment tools to pick out the items that we felt conceptually would be most likely to be useful as a screen. And then we started honing down those 15 items to see which items produced the best accuracy. The 6 UNCOPE questions actually emerged as doing a better job of any of the other combinations or the 15 items as a group. So the first 5 items here cover 5 different criteria in the DSM-5 and also the DSM-4, actually. The last item, the have you ever drunk or used to relieve emotional distress, such as anger, loneliness, boredom, is a self-medication type item. So the UNCOPE can be used as a general screen, or it can be used to focus on specific substances. Recently, there was some flurry of interest in developing a screen specific for stimulants and opiates. But as we'll see in the next slide, we really didn't need to do that. Because the UNCOPE, when you ask the question specifically for opiates and meth, get you very high sensitivities and specificities. The other 3 substances are looked at on an earlier study. Both of these studies have been published, by the way. As you'll see, the specificity is very high. There are very, very few false positives, because if you use a cut score of 3 or more to indicate a serious substance use disorder, which is what we see here, you already have at least 2 positive criterion indicated by the screen alone. So the specificity is quite high, that if you hit 3 or more, the odds are you're going to hit 5 or 6 or 7 or 8 or 9. The anomaly here seems to be for alcohol and cannabis, and I'm not quite sure why we're missing more people there who have positive indications for a serious substance use disorder. What we do know is that with alcohol and cannabis, there's a much greater proportion of people that we find in the mild to moderate range. With the cocaine, opiates, and especially opiates and meth, it seems to be more of an all or nothing thing. Either the person doesn't have any issue with the substance, or they're already over in the serious range. So there seems to be much more of like an on or off switch with some of these more, possibly you might call them more addictive substances than you do find with alcohol and cannabis. And cannabis in particular is one that typically has the fewer positive DSM-5 findings. Next, please. So how can you get the uncope? Well, a Google search will do it, or you can access this file when the webinar is over. Children and Family Futures has an excellent video using the uncope as a checklist in a mock interview of a woman where child neglect is an interest. The thing you see at the bottom there is a snapshot from that video. It's an animated video where the individual is going through a rather free-form discussion with the individual, but checking off the uncope items as they come up in the conversation. So overall, if we're looking at severe with 3 or more positive indications, on the screen, 3 or more positive indications on the screen, which will give you 6 or more positive total. The sensitivity is 85% or higher, as you saw before, for the individual items. And the specificity is around 97%. So you have very, very few false positives. If you want to drop the cut score to 2 to catch the moderate to severe diagnoses, you get very similar sensitivity and specificity with the uncope. So bottom line is the uncope is a pretty universal screen. It has also been validated on adolescents in juvenile justice populations. So it's a screen that is useful for any specific substance, for substance in general, and for adults as well as adolescents. Next, please. So where do you screen? Well, obviously, we talked about mental health clinics, child protection investigations, as would be the case in the video that Children and Family Services has. What we have seen in rural jails, at least, and probably from the literature in urban jails as well, is that probably about 2 out of every 3 people booked into a jail has at least one serious substance use disorder. We've done a lot of work in rural jails. We have found that in one jail, for example, 93% of the people have at least a mild substance use disorder of one sort or another. So correctional populations are quite high in terms of the probability that there is a substance use disorder there. However, in most cases, it's not practical to evaluate everybody. So a screen can be very useful in this instance in eliminating the third or so of the individuals who probably will not show up positive on a detailed diagnostic workup. Juvenile justice has very similar problem prevalences. Data we've looked at in juvenile justice as well as in juvenile adolescent treatment programs show that a lot of the problems in the 2 populations are relatively similar. One area that everybody seems to be missing, as far as I can tell, are general hospitals. About 1 out of every 4 people admitted to a med-surg unit on a general hospital will have at least one substance use disorder. And that's for your things like surgery, oncology, urology, and all the other ologies. And also in orthopedics tend to have relatively high prevalence rates of substance use disorders among patients being treated for severe injuries. Social services and people applying for social service programs would be another place where screening might be appropriate. Marriage and family counseling is yet another. So screens can be used in a variety of issues, in a variety of settings. Now, screening for mental health conditions gets more complex because you're dealing with a broader range of conditions that have different kinds of diagnostic criteria. It's logical to screen for the most common conditions. You don't probably want to screen for very rare conditions. That would, in most instances, be much of a waste of time. However, for those conditions that you're likely to find, it would be good to do screening there. What we have found in correctional populations is that the most prevalent conditions are major depression and PTSD. There are some existent screens for some of these conditions, as well as some that we have actually developed. Next slide, please. Prinz and his colleagues came up with a 4-item scale, which is actually 8 because all of his items are double-barreled. Have you experienced this or that? Have you done this or that? We actually came up, one of my graduate students is the lead author on this, a 2-item screen for PTSD. And it's simply, if you've ever experienced or witnessed a traumatic event, have you experienced intense distress when something reminds you of the stressful event? Or have you actively avoided thoughts or feelings associated with the event? If you get both of those items, yes, the odds are you're dealing with somebody that's likely to have some substantial indications of PTSD. We played around with other items, and we actually found a total of 4 items that in pairs produced a relatively common positive result as far as accuracy was concerned. Next, please, we'll look at depression. Here we have another 2-item screen that we developed that goes, if you've had a period of 2 or more weeks where you felt depressed, blue, or sad, did you have trouble thinking or concentrating, or did you have little energy or were easily fatigued? Again, we found that these 2 items did the best, but that any 2 items that cut across different diagnostic criteria seemed to do reasonably well. Not quite as good as these 2, but did give you some indication that you're dealing with somebody that may need to have a workup for depression. Next. This is the sensitivity and specificity for the depression and PTSD scale. These are lower than the UNCOPE, but considering the brevity of the scale, they're still not too bad, and would be helpful in flagging individuals where these conditions might be a problem. Next. So, general issue. 2 to 6 items seem to go very well in doing screenings. No 2 items on a screen should load on the same diagnostic criterion. The item content should be concrete and directly related to the criterion question. No subtle or indirect items really don't add to accuracy whatsoever. You also don't really need a validity scale for a screen, or for that matter, for most assessment tools, if you make the items very concrete and precise. Next slide, please. So, diagnostic assessment. The diagnostic assessment should cover the criteria for the condition under consideration. In this case, substance use disorders is our primary focus. They should provide diagnostic indications for all of the categories, and usually with 2 or more items per category. Also, you might delete some of the rarer substances that you rarely see in your inquiry, but it's good to, first of all, ask whether or not an individual has used all the given substances that are noted in the DSM-5. It requires a one-on-one time, FaceTime kind of thing. You could use a Zoom. I don't recommend phone conversations for an assessment, but a Zoom assessment totally is possible, because with Zoom, you know the individual who is answering the questions is the individual that you are trying to evaluate. Doing remote assessments, it can be tricky, because you do want to make sure that the person answering the questions is indeed the person of interest that you're dealing with. And ideally, we use a structured interview, as I mentioned before, to do the assessments. Next slide, please. Okay, as I mentioned, 2 or more questions per criterion. Screening or coverage of common co-occurring mental health conditions should be used in most situations, because there is a very large number of individuals that have conditions in both mental health as well as substance use. Again, the one face-to-face or via or Zoom connections is the way to do this. Next, please. Okay, the advantage of an interview is it ensures coverage of the targeted conditions. The interview itself can be done by any appropriately trained person. With some of the online tools, the system drives the interview, so just about anybody can administer the questions and record the answers. The advantage of a structured interview, it can facilitate generation of reports that are very factual and offer much more information in less time than most free-form interviews will allow you to cover. Next, please. Next slide.
This is the next slide.
Oh, I'm sorry. Questions should be concrete, matter of fact. If the questions are properly designed, they actually do not require validity scales. One of the best answers I ever got from a patient, blue-collar guy, when I was in private practice, when I asked the question about, has anybody objected to your drinking? He looked me in the eye and he said, well, hell, doc, I told you I was married. As far as he was concerned, that was a sort of a trick question. That was a validity question because if you were married and you said that your wife didn't complain about your drinking, you were obviously lying. So the more concrete the question is, the more likely you are going to get a very concrete and accurate answer. There is nothing that you can do to preclude somebody from falsifying information of a negative sort, that to deny events that have occurred. But for most people, a concrete question is answered as a concrete answer. And you don't have to do any value judgments. As I mentioned earlier, each question should cover only one issue or problem. They shouldn't be double-barreled. In some cases, you want to use presumptive wording. For example, in the adolescent interview that we've developed, the question is, how old were you the first time you got intoxicated or high? The presumption is you obviously got intoxicated or high. And you then let the individual tell you that, no, I haven't done that, or gives you an age of when they first got intoxicated or high. So presumptive wording is another possibility of for some types of information that will give people permission to acknowledge that they have in fact had these kinds of experiences. A good diagnostic interview or structured interview will also provide the results in a way that it's easy for clinicians to then interpret or to build upon. It will give you the summary information of how many criteria are positive and exactly what kinds of questions support that conclusion. An interview, in most instances, needs to be administered in less than an hour. Because you have the clinical hour and outpatient programs. And also, you don't want to overburden the individual with a long multi-hour assessment. And you have to keep in mind that the mind can focus only so long as the bladder can endure. So it's necessary to, in most instances, keep the interview to about an hour. Next slide, please. As I mentioned before, adults and adolescents can be evaluated, but they're different. Adults are more likely to talk about substances and might be a little nudgier to talk about things that involve some mental health conditions, such as PTSD, perhaps, or antisocial personality indications. Adolescents are just the opposite. They don't want to talk about their substance use at all. But they are perfectly happy to tell you how crappy they feel in most instances. So with adolescents, the strategy is to start with depression and anxiety conditions, then move into things like conduct disorder and oppositional defiant indications, ADHD, and you end with the substance use disorders in the interview after the individual is warmed up to the topic. With adolescents, you also find that you often develop what I call a test-taking mindset. Because you're dealing with a finite script, excuse me, you have the set of questions before you, or you're working off of a screen online, and it's very clear that you're going to ask all these questions, and the next question is not based on the answer to the previous question, but because the two of you are going through this test. And often adolescents slip into a test-taking mindset where they will acknowledge things that they might not necessarily acknowledge. The first time we took our adolescent tool out for a test drive was at an adolescent girls treatment program. And during the course of the interview, the young lady acknowledged some physical abuse that she hadn't shared with staff. She'd been in the program 2 months, but the fact that the question was embedded in the other questions, and this was a test, and you want to get good answers to a test or else you get a bad grade. So the process of a structured interview can enhance what people tell you. Next question. Next slide. So you have two options, really. You can build your own, or you can buy something that's already put together. The advantage of doing your own is you can tailor to your specific program population or special factors in your program. The disadvantage is you might not use best wording or get good accuracy. And when you've been at this a while, like I have, you learn a few things about what seems to work and what doesn't. If you're going to buy a commercial assessment tool or use a commercial assessment system, you want to make sure that it's well constructed and researched. You want to be able to look at all the questions so you can get an idea of what's being asked, so you understand exactly what it does. You don't want something that this is a computer program, you're going to answer the questions and it goes into a black box and it comes out this way. You want to know exactly how this thing works. The disadvantages, most of these have some cost to it, but my experience has been a lot of the free assessments are worth exactly what you've paid for them. But you all do need to be careful about the test that's being proposed to be used, how it's scored, how the process gives you feedback. Is it a report? Does it generate a report or allow you to produce a report that is meaningful to you in a way that's convenient? Next slide. Now, no matter how you come about your assessment, the assessment is really not going to be terribly effective unless the patient gets a VAHA experience. VAHA, VAHA. This is what the patient wants and needs if the patient is going to engage with you. First of all, the patient needs validation that the condition warrants treatment or attention. Then the patient wants an assurance the condition is treatable. The patient wants hope. A positive outcome is not only possible, but likely. And finally, an action plan, a logical, realistic way to proceed. And if the individual does not get this, the odds are they may not come back to an outpatient program for another visit, or they may not engage in the residential program. And a VAHA experience might look a little like this. I'll do a very condensed version that would be based on, say, the individual information you got off of a CAPE 5 interview. Well, Mr. Jones, it looks like from what you've told us, you have a serious opiate use disorder and a moderate alcohol use disorder. Additionally, you have some traumatic experiences apparently that may be related to the panic attacks you're describing and to the indications of PTSD. Now, we're most concerned at this point about the opiate condition because if your drugs are laced with fentanyl, that could result in an inadvertent overdose. You're not injecting now, so that's good. So we don't have to worry about an overdose from an injection. But these are conditions that do require treatment, and I think we can help you with that. The good news about this is that these conditions are all treatable and that a number of people have been able to recover from both the substance use disorders as well as dealing with other mental health conditions. Our program in particular, I think, would be a good fit for you because we have clinicians that are well-versed and experienced in treating these conditions, and we have had good positive outcomes for a large number of individuals. We have a good track record on doing this. And what I'd like to begin with is to see whether or not our residential program might be a good place to begin to deal with your substance use disorder issues. And then as we get you cleared of drugs, then we can begin to see whether the indications of PTSD and anxiety attacks might be related to the drug use or whether they are occurring as independent entities. So is that a strategy that makes sense to you? So this individual, in a very condensed fashion, has gotten a VAHA experience. Validation, yes, he's got a condition that requires a treatment. Assurance, yes, it's a treatable condition. Hope, this program is good at this. And an action plan that makes sense. So the bottom line is that the VAHA experience is definitely something that patients are looking for. If they do not get it, I think it accounts in many cases for why the modal number of visits in a mental health clinic is one. The individual comes in and never comes back. In a treatment program, if you spend an hour or two going over the person's history and when they first used alcohol and when they did this and what their relationship with their alcoholic father was and so on and so forth, you're likely to tax them to the point where they're not sure they really want to go on with this because they can't see where it's going. Next slide. Okay, we're going to very tangentially cover a few points. Treatment monitoring is usually done vis-a-vis chart notes. There are some commercially available instruments to provide a means of systematically documenting whether key areas covered in the ASAM criteria are improving or not improving, as the case may be. But I think most programs rely mostly on chart notes and some internal documentation that they have developed over time. Next slide. Assessing a treatment outcome, as I mentioned earlier, does not require a validated instrument. To claim that it requires a validated instrument is from the Researchers' Full Employment Act. The question is, did the patient achieve remission? Did the patient reach a state where they no longer have a positive finding for any of the 11 DSM criteria in a specified period of time? For early remission, that's 3 months. For extended remission, it's no positive findings over the course of 12 months. Quality of life scales and some of the so-called the valid instruments, the GAD-7 and PDQ-5 and so forth and so on, are fine and dandy and will add additional information to how people are feeling. But the basic question that people will have is, did the person achieve remission? Did the treatment work? Did they resolve their issue with the substance use disorders? Effective treatment, we've known from all the outcome work we've done, really requires 3-month scheduled contact. And that is that from intake to the last scheduled visit should be at least 3 months. If that time frame is much shorter than that, there tends to be less positive outcome that you can document. So the time that every individual should ideally be in contact with the treatment program gives you an opportunity to document at least initial remission. Next slide. So how can you do that? Well, in 3 months, from intake to the 3-month mark, you should be able to cover just about everybody. How you do that is with about 8 questions. The first is, have you used any substance in the past 3 months? If that answer is no, then you're home free. You will notice that the remission definition does not stipulate abstinence. It stipulates that you have not had any positive DSM-5 criteria in the period designated. So if the answer is yes, we have to ask a few more questions. We'll begin with the uncope questions, which would give you a real good indication of whether or not the individual has continued problems. And then you have one last, the eighth question, which is a catch-all. Have you experienced any other adverse consequences due to your use? To try and find out if there's any of the other positive of the criteria that's still positive. I would be willing to bet, based on over 40 years of doing this, that if you got somebody that even acknowledged some use but denied the rest, that you would be in pretty good shape of having documented remission in this particular instance. Next. So that's the end of the formal presentation. I think we've burned through about the better 3/4 of an hour to do this. And now we'll entertain some questions that Valerie may have from people who've sent in things earlier or things that have come up during the course of my babbling on.
Yes. First of all, Norm, thank you so much for taking the time to share your wisdom and expertise with us on this particular topic. I know I have learned a lot. I'm sure the audience with us today has also learned a great deal. So thank you so much for sharing. I'd like to start by posing one of the questions that came up in registration, because I know a number of the folks we have on the call today do work in the correctional system. So this question is directly related to that. How do we leverage behavioral health assessments within the criminal justice system and use them to coordinate care between the two entities? What insights do you have on that?
Well, it kind of depends. This depends upon the system and the situation. In the rural jail, you're dealing with a very quick turnaround in some cases, where you have an uncertain departure time for the individual. So in a jail, you're limited to identifying problems and making referrals to people in the community. And that requires having relationships with providers in the community, which is an area where we're seeing progressive sheriffs increasingly, because sheriffs usually are the ones in charge of the jail under their auspices, realize that they can't arrest their way out of this, that they need to work with providers. In the case of state prison systems, you have a designated time that the individual is going to be there. And you then have the option of providing the addiction services within the prison, or coordinating or contracting with people outside the system to come in either to the prison or to pick up the individual when he or she leaves the confinement. And the same thing would be true for the federal system. I believe what we tend to see is that local jails have the highest prevalence rates for behavioral health problems. When you get to the state system, it's a bit more rarefied population, if you will, because some of the individuals that would have been in the jail with these problems may have been referred back out into the community to providers there. And I think the federal system might have an even more rarefied system as far our population as far as behavioral health conditions. So it's been a challenge, because one of the challenges we have seen doing research as well as clinical consultation in this area is that there seems to be a silo of correctional researchers and correctional people, and a silo of behavioral health people who don't necessarily interact with each other in the most effective way possible, and also often ignore the realities of dealing with the conditions that people are dealing with in these systems, and how the conditions contribute to the offending. We found that for one sheriff, for example, we converted the amount of county resources dedicated to simply housing people in his jail with their behavioral health conditions. And we found that if the individual had neither a stimulant nor an opiate diagnosis, on average, over the specified period of time, they cost a county about $4,500, $4,800, $3,800. If they have one or the other, they cost a county over $4,000. If they had both of those conditions, they cost a county over $6,000. So stimulant and opiate use disorders are one of the strongest associations with recidivism into the criminal justice system. And a lot of preoccupation has been done in corrections on the severe mentally ill, and they often miss the PTSD issues and the depression issues and the other kinds of issues that are actually more prevalent.
Great. Thank you so much, Norm. I'm going to pose, I think we might have time for 1 to 2 more questions, but this clarifying question from Jessica, I think is relevant here. She says, I'm trying to visualize what it would look like to go from screening substance use disorder to diagnostic, as many of the criteria are already discussed in the screening portion. So it almost seems the screening portion may be longer than the diagnostic. Can you offer some clarification on that?
No, no, the screen, 6 questions can do it for substance use disorders. To do a full diagnostic workup is going to constitute more like 40 to 50 questions when you're covering multiple, and it's going to take about, with a structured interview, a diagnostic interview will take about between 35 to 45 minutes, maybe 50 minutes, depending on how much you find with appropriate branching. But the screen is going to take you about 5 minutes, if that.
Great. Thank you. Let me pose one more because this came up in registration, and I know you have some background in this. Someone's asking about the best screening and diagnostic tools to use with Native American population. So this is a population-specific question, and I know you've had a little bit of experience.
Yeah, I have a background some years back. I think the most recent assessment training I did was for the Dene at their Two Arrows casino. But I've worked with the Blackfeet, the Fort Peck tribes, the Northern Cheyenne, and various other tribes, as well as the Indian Health Service offices in Phoenix and in Memphis, or not Memphis, Nashville, I believe it is. But the diagnostics will work in Indian country, I think, as well as they will with the Caucasian population or Black population or other minorities. The caveat there, though, with Native peoples is there are other issues in developing the treatment plan that need to be considered. How culturally traditional the individual is or not, as the case may be, and other issues concerning the other factors. Are you on a res or are you in a city, in an urban area? Just because the individual is a Native person doesn't necessarily mean that he's on the res. So we have to be cognizant of issues other than the diagnoses, but it seems that the diagnosis is pretty universal no matter who you are, that there are certain things that tend to occur. And if the diagnostic workup is appropriate and competent and capable, it should pick it up.
Great. Thanks so much, Norm. With the last couple minutes here, is there anything specific that we didn't cover, things that come up a lot for you that you'd like to share with this group?
No, I think I tried to hit the high points. My contact information is on the last slide. So if anybody has any questions or needs clarification on any points, they can contact me directly. My email as well as my cell phone is there. So I welcome anybody who wants to chat to give me a call or drop me an email.
Thanks so much, Norm. That's very generous. And everyone, will make sure that that contact information is included in the follow-up email containing your recording early next week. So thank you. Thank you again, everyone that was able to join, pose your questions. Just one quick takeaway, I see that there are a lot of questions specific to the ASAM criteria. We do have a bi-monthly webinar specifically addressing questions related to the ASAM criteria. So I've taken note of these and a number of questions that I think we could bring Norm back and spend even more time. So again, these questions are being logged, and we'll keep them in mind for future webinars.
Yeah, I'm not that versed in the current ASAM criteria, but I was the lead author on the very first ASAM criteria, so I do have a fleeting familiarity with the ASAM.
Yeah, I'd say probably more than fleeting, and yes, this is an area of interest for many of our folks. So thank
Okay.
you again, everyone who joined us. Thank you so much, Norm, for sharing this presentation with us, and we'll see you all next time. Take care.